Welcome to Barbershop Talk Live. I am your co-host, Alava Blood Lighthorn. Today, we're going to have a conversation about trial study on cancer, and how important it is to participate. Starting from my right to my left, will you please state your name and your organization?
Thank you for welcoming me. My name is Dr. Mohammed. I am a research scientist.
Thanks for the invitation. I'm Dr. Leon. I'm a medical oncologist at the advocacy.
Blood Lighthorn, co-host.
Derek Nelson. Thank you. Yep, so at this time, we're gonna open the floor up and the options to speak.
Go home, with some lessons, hopefully an action plan from the top. So if you go to the slide. So this is kind of the outline of my talk. So again, some generalities about what the liver is. What is considered primary liver cancer versus secondary liver cancer. That's a common point of confusion. Just because you have cancer in the liver doesn't mean it's autoimmune. We'll clarify that a little bit, and then get into how primary liver cancer actually develops, how common it is, how it's diagnosed and staged, and how that stage informs how you treat it. And then in the last few slides, I'll talk about the importance of participating in clinical trial and research studies, and then hopefully give you some pearls that you can take home with. So next slide. So this is a schematic of the body, but I'm highlighting here the liver. The liver is one of the largest organs, probably the largest organ in the body. It's located on the right side of the body, in the belly cavity. It plays a lot of functions, probably over 500 functions. And, so what I want to highlight is just the detoxification. It's a detoxing. So it filters blood, gets rid of a lot of toxins or harmful materials, and returns that blood to the heart. So you can imagine if your liver shuts down, really things can go south pretty quickly. If you know someone who's had liver disease, they can crack pretty quickly. So it's a very important topic. It also makes a lot of substances that are really critical. You need to live, so the protein, good cholesterol, and you may have heard about the liquid called bile, that greenish fluid that helps digest a lot of food, fat, and it's stored in the gallbladder that sits right underneath the liver there, and that's the diagram. Next slide. So in this slide, I really want to clarify what liver cancer is. Liver cancer, when you see a cancer or mass in the liver, it could be three different things. It could be cancer that started in the liver. We call that, hepatocellular carcinoma. And that's, arises from the liver tissue. That's about 80% of the Next. So, it's a multi-step process. So a lot of things have to happen before you get to liver cancer. And there's one thing called chronic hepatitis. Hepatitis just means inflammation of the liver. That happens chronically, meaning over years. And a lot of things can cause that. I'm listing there 4 groups, categories of cause of common risk factors. Alcohol, as most of you probably know, it's the most common liver toxin that can cause liver disease or chronic inflammation. The virus called hepatitis, it comes in different flavors, hepatitis B, hepatitis C. That's also a big common cause. And then the last category there is something, a big technical term, but it's pretty much saying fatty liver disease. That's not related to alcohol. That could cause, inflammation of the liver over time. Next. So that chronic inflammation list is something called cirrhosis. Some of you may have heard that term. It pretty much means, repeated damage to the liver. So if you have a burn or a cut on your skin, it will heal. It will leave a scar. If you have repeated cuts, repeated burns, you can imagine over years, your skin is not going to look the same. And that's what that picture is supposed to depict. That chronic inflammation or repeated damage changes the texture of the liver over time. And that's what's called cirrhosis. When you have cirrhosis, your liver is not functioning well. Next. And then eventually, the last stage is cancer. So people could have chronic inflammation, cirrhosis for years, but then eventually it turns into cancer. And once you diagnose with cirrhosis, you have to be screened almost every 6 months, typically with an ultrasound and a blood test called an AFP, and I'm going to talk about that later, to make sure that we catch cancer early because you get high risk. Next. So I'm talking here, this slide is just kind of summarizing what cirrhosis is. That's a common question I get. What is liver cirrhosis? It's a different disease. It's one of the strongest risk factors, like I said, because of that repeated damage. And what happens in cirrhosis, because of that scar tissue, that chronic scarring, you can see the blood vessels there. I told you that it returns, because one of the roles of the liver is to return filtered blood back to the heart. So if you have that repeated scarring, it affects the blood flow. And so the blood is going to pool or stay in the liver, and you can see how those veins become dilated. If you know someone who has varicose veins on their legs, the same thing can happen in your stomach or your esophagus. And those veins are not supposed to be that dilated, so they can pop up anytime and bleed. So that's what a lot of people with cancer or cirrhosis will bleed. They have bleeding complications, usually upper GI bleed or hemorrhoids. Those hemorrhoid veins are also very thin wall, and you're not supposed to have a lot of blood. They can pop up and bleed. So cirrhosis, that's what cirrhosis is. And so you may know people who have symptoms, signs of cirrhosis. So that's where that comes from. Next slide. Here I'm highlighting some of the risk factors. I kind of touched up on a few of them, but I want to just be comprehensive. We talked about infections like hepatitis B, hepatitis C, other common infections. Fatty liver disease that's not related to alcohol is also a common cause of cirrhosis and eventual liver cancer. Alcohol is the most common liver toxin. So if you drink, you use alcohol, high amounts for a number of years, eventually will damage your liver. And then there are other environmental factors like aflatoxin, which is a fungus, not so much common here, but in Asia and Africa it's common. And then other genetic diseases that cause accumulation and deposits of iron and copper in your liver, and eventually over time it damages the liver. So those are, just to be comprehensive, the common risk factors for cirrhosis and liver cancer. Next. So this is just to give you a distribution, an idea of globally, the distribution of liver cancer. So the 6th most common cancer worldwide, 2nd leading cause of cancer-related death. And more than 2/3 of patients are diagnosed with not eligible for curative treatment options. By that I mean surgery and liver transplant. I'm going to get into that in a little bit. So the majority of patients, by the time they diagnose, usually either too advanced or they're not eligible to get those curative options. The 5-year overall survival is about less than 20%. And in terms of the causes, where you're from in the world also determines the type, what causes your liver cancer. In Africa, Southeast Sub-Saharan Africa, Southeast Asia, viral hepatitis B is a common risk factor and accounts for probably 60% of people. In the West, it's a little bit different. You see a mixture of hepatitis C, alcohol, obviously fatty liver disease related to obesity and diet. But depending on where you are, where you migrate to, the cause, the etiology of the cancer might be different. Next. In the US, it's projected by 2035 to be the third leading cause of death by 2035. So it's one of those cancers that's rising in terms of incidence and mortality. Next. What about in our area, in Minnesota? This is straight from the Department of Health, Minnesota Department of Health, and you can see there that the highest incidence of mortality for liver cancer is, from populations of color, Hispanics, and American Indians. And you can see there the mortality, the incidence, the highest is in Black or African Americans, and the mortality second to the highest. So, the minority patients, racial or ethnic, are disproportionately shouldering the burden of this cancer. Next. And what about the causes? I talked about a couple of these factors, hepatitis being one of them. I'm showing you here again, straight from the Department of Health, the incidence of viral hepatitis in Minnesota by race. And you can see here for hepatitis B and hepatitis C. And again, the minorities, including Black and African American, shoulder that we have a higher incidence of hepatitis. Next. Now I'm showing you here some work from Dr. Chair, some of the earlier work about 2010, almost over a decade ago, looking into the prevalence of hepatitis C in Homestead County, among Somali immigrants. I told you in that one of the previous slides that in sub-Saharan Africa, it's a lot of hepatitis. That's what causes it. And so what he found in this study that was published in Mayo Clinic Proceedings, I think in 2010, was that compared to their white counterparts, the Somali had a 10-fold higher incidence of chronic hepatitis B. And for hepatitis C, it was 3-fold higher. And in general, Blacks in Minnesota had a age-adjusted incidence that was 4.2-fold, almost 5-fold higher than their white counterparts. So again, showing that we are, racial and ethnic minorities at a higher risk of, getting liver cancer because of some of these risk factors. Next. And this is a study that was expanded upon and replicated almost a decade later by my colleague here, Dr. Isa Mohammed and Dr. Nasra Jama, showing again confirming those results, showing really the breakdown of not only the incidence, showing the high prevalence of hepatitis B and C in the Somali immigrant community in Homestead County, but also you can see the breakdown depending on the age and what type of hepatitis. And he's going to talk about that later, so I won't expand too much. Since he's here, he's going to talk about it. You can go to the next slide. So how is it diagnosed? And I'm going to start here with some of the common symptoms that you can see. And many people actually do not have symptoms until it's advanced. And I showed you cirrhosis, what cirrhosis looks like and what it can cause. But when you get to that point, it's really late. That's why you have to be screened early on to detect the cancer early and act early. But listing here some of the common symptoms, and I'm glad we have a patient here who can kind of relate his own experience with this, but they range from pain in the belly, typically on the right side, nausea, vomiting, loss of appetite, weight loss, unintentional, and jaundice. Remember I told you one of the functions of the liver is to process that bowel. So if you have blockage for whatever reason, bowel is not exiting, it backs up into the blood, and that's what turns yellow. So if you see someone yellow, skin yellow, the sclera, the white part of your eye is yellow, that's usually a sign of liver disease, and usually cancer or cirrhosis. Because of one of the functions of the liver is to produce proteins that help with clotting, clotting factors. If the liver is not functioning well, you're at high risk of bleeding and bruising. So patients, you may rub against the wall and you easily bruise because some of those factors are deficient. The same reason why you turn yellow is the same reason why your urine will be dark. That's again bilirubin into the urine. So dark urine, yellowing of your skin, a typical common thing. But usually that's a sign of an advanced disease. You don't want to wait until it gets there. So that's why it's very important to screen early. Next. In terms of testing, usually this is just for your awareness, but there's a lot that goes into it. It ranges from blood. We could look at your blood counts, your liver function tests. There's one marker that tends to correlate with disease activity, cancer activity. It's called the AFP, alpha protein. Not always, but it's a common marker. So if you have cancer that's aggressive and growing, typically it will produce that protein, and we can detect that in the blood. That's one of the things we use when we screening for liver cancer, in addition to the liver. So that's called AFP. In terms of imaging, the ultrasound is what we typically use for screening every 6 months. But once we concern that there may be something, you usually get a more advanced scan called a CAT scan or an MRI. That really gives you a better definition of what's happening in the liver. And this is one of the cancers that actually you can diagnose just based on the scan. So a lot of cancers, you have to get a biopsy. This is one where we know the classic sign, of liver cancer or HCC, and we can tell this even with the scan without a biopsy. But nowadays, because we can easily do biopsies and we can always learn from a tissue that we obtain, we also routinely get biopsy for the liver. So those are kind of in general what will be involved while we evaluating someone for liver cancer and to come up with a diagnosis. Okay. Here I'm putting the stage, and this is a kind of a simplification, simplistic model, but it gives you a sense of, what is considered very early stage, where you can just have one small nodule that's like less than 2 centimeters or so, versus, early stage where you have maybe a couple of small nodules or one slightly bigger nodule. Stage, a more advanced or intermediate stage where you have it in 2 different lobes of the liver. And then an advanced stage where it's in different places in the liver, or it's already started to spread outside of the liver. That's called advanced disease. And then the last stage, we really advanced to the point where not only do you have liver cancer, but your cirrhosis, which is damage of the liver, it's also very advanced that those patients cannot even handle treatment. So that's a very advanced stage, and that's the last. And the stage informs how you treat. We can go to the next slide. So how is it treated? Next. So again, this is kind of a brief summary of the different stages that I just reviewed, and then you can go next. So for very early stage and early stage, we typically would at least evaluate the patients for ablation. It's like literally burning a small lesion with heat energy. For surgery, so the patient will be evaluated for that. If you have a single small lesion, we'll evaluate you for that. Next. For intermediate, so where it's a little bigger or it's in different places, typically we'll consider something as a group of therapies called intra-arterial therapies, meaning we use, because this tumor relies fully on blood supply, blood vessels to grow. So we can use that to introduce treatment. We call them chemotherapy, part of the chemoembolization, radioembolization. So we use that blood supply that the tumor heavily relies on to send treatment. Radiation therapy is pretty much using, again, the type of energy, radiation energy to burn the tumor. And next. And then transplantation, meaning there's set criteria, which I'm not going to go into here for the sake of this discussion, but if you meet the criteria, you can be eligible for a transplant, meaning we take out your whole liver and we put a new one. Because that's a huge undertaking, they have very strict criteria for that. So not everybody is eligible for it, but that's an option. Next. And then if it's advanced, meaning that you're not eligible for these local therapies, it's spread outside of the liver, we use systemic therapy, meaning it goes in your whole system. You can't do local therapy because you won't be able to treat the whole disease. And that's in the form of immunotherapy. A lot of you, cancer patients, you know about chemotherapy. Chemotherapy just kills rapidly dividing cells. The good and the bad. We hope that it kills more of the bad, but that's why people lose their hair, because hair cells divide rapidly. It's pretty tough. Thankfully, in this cancer, chemotherapy doesn't even work, so we don't use that in this. But we use a different type of treatment called immunotherapy, which boosts your immune system to attack the cancer. Your immune system is designed to recognize anything that's foreign and go after it and get rid of it, but like an infection. But the cancer cells found and hijack that mechanism and put it so that it can evade surveillance from the immune system and they continue to grow. The immunotherapy is designed to boost or wake up your immune system and remove those breaks and allow the immune system to do what it's supposed to do. And when it works, it can work well for a long time. It's really changed the game for a lot of cancers, including liver. The other type of treatment there is targeted therapy, which pretty much targets specific mechanism that'll allow the growth and the proliferation. And then I put there in red clinical trials, because I showed you the statistics for this cancer, they're not good. So we're always trying to move the needle and improve on the current standard of care. So always considering clinical trials across the different stages, the normal clinical trials. Sometimes, most of the time, it's the best option because it builds upon what standard trying to improve upon it. as we'll find out in a little bit here. Next, and I'm just here, you go next. This I just kind of know what you'd expect in terms of survival across the different stages. So you can see the earlier you diagnose, the better treatment you can have, the higher the chance of cure and long-term survival. The later it is, the poorer the outcome. So that's why it's very important to get screened early. And a lot of patients, unfortunately, because they don't get screened, 50% have intermediate or advanced disease when they're diagnosed. It's usually a little later. And that's sometimes the missable. So next. I wanted to talk a little bit about clinical trials and clinical research, because like I mentioned, it's very important because this is an area of unmet need. It's not like diabetes or hypertension where we have treatments that are working if you take them. Here, we're trying to improve outcomes. So the only way we do that is through research and clinical trials. And I'm defining here what a clinical trial is, which some of you may not know. But a clinical trial is pretty much a study in human volunteers that's trying to evaluate the medical product, whether it be a device, a drug, a vaccine, and assess the safety and effectiveness in humans. And that's the process that it has to go through before it becomes approved and available to everybody. We need to make sure it's safe, and we need to make sure it works. And that's true clinical trials in multiple phases. And then around that, with that wheel to show that what we learn from the lab bring to the clinic. And what we learn from the clinic, from the patients on how they're handling or tolerating treatment, we go back to the lab and refine, go back to the drawing board and say, okay, this didn't work, this is what we need to modify to make this work. So it's kind of a cycle, and really research is what drives innovation, and that's a very important part. Next. And again, I'm summarizing here the different steps, but let's put it simply, you may have heard phase 1, phase 2, phase 3 clinical trials. So we start with initial experiments in the lab in cell and animals, mice. We learn a little bit and we bring it to phase 1 clinical trial. So first in human clinical trials to see if it even safe, what is the right dose. And then based on that, if we get a good safety signal, we move it to phase 2, where we test it in broader population to see if it works. And at that level, if it's reassuring, then we go phase 3, which is usually bigger trial, multi-center, global, different countries. So there's a really multiple steps. And even after that, if after the phase 3 trial, the results are good, the next step is making sure that we deliver it to the patients, the different communities, and so there's post-trial analysis, and that's usually a later stage. But even after we bring a drug to the market, we need to say, okay, in a real world experience, what does that look like? So it's a multi-step process. And it's very important for us all to be engaged, because if you're not represented, guess what? It's safe for them, but not for us. We don't know, right? Does it work for everybody? We don't know. So if you're not represented, then we cannot say this drug works for everybody. So it's very important for all populations to be involved and participate. Next. Here I'm showing that, this is data from the FDA, the Food Drug Administration, looking at oncology trials, so cancer trials in the US and overall. And you can see that the majority of participants are white, Caucasian, right? Black and other racial and ethnic minorities, very low, right? And that's part of the problem. So a lot of the medical products that we bring to the market are basically in majority based on data from Caucasians. So how do we know it's safe, right, in certain populations? We need more representation, and we see that. Oh, this drug is wonderful. Try it in a patient, it doesn't work. Why? You go back to the data, less than 1% were represented in that study, right? So we need to, increase that representation. Next. So this is the same topic that I'm trying to emphasize here, to say that, if you want to bring a study, for a certain cancer, you have to make sure that you test that in a population that's reflecting that disease. I showed you the epidemiology of liver cancer, the map initially. It's different populations. It's not one, it's not a homogeneous population. And they all react to drugs differently. They all have the efficacy may be different. So we really need to make sure that if this product is intended to be used for all, make sure that when we test it and we assess it in all patients. And that's kind of what that slide is getting. Next. So I'm going to take here in the last few slides an example, a real world example. Sometimes it's good to be practical. And this is a clinical trial that actually I lead at Mayo Clinic, along with one of my mentors, Dr. Roberts. It's a phase 2 trial. So I told you about the different phases. So we started, phase one, there was a safety signal, and we decided to, based on that, phase two trial. For patients with unresectable liver cancer, so patients that were diagnosed or for whatever reason are not eligible for resection surgery or transplant because of they're at a later stage or they have other issues. We know that those patients, the chance of cure is the highest with surgery. But for those patients that miss that opportunity or that window, what can we do to improve the outcome and still get them to close to that? And that's what this trial is attempting to do. So that's for patients with unresectable liver cancer. And what is combining multiple modalities. One of them is radiation therapy. So we burn the tumor. The other one is dendritic cells, and I'm going to talk about that a little bit. The type of immune cell that's designed to what they call antigen presenting cells. So their job is to recognize anything that's foreign and alert the rest of the immune cells, the immune system, the killer cell, to say, if it's foreign, you can get rid of it. We're combining that with another type of treatment called immunotherapy. That's a type of treatment that's designed to remove those breaks that the cancer cells have. Those multiple treatments that we're using in one to maximize the outcomes for patients who missed out on the opportunity for surgery. Next. So I'm putting here, it's very technical, but it's just to show that there's rationale, there's a reasoning behind what we could think, we're not just mixing and matching. There's a reason why we use different things. And the radiation at the very, where you see the EBRT, radiation burns the tumor. The tumor will release tumor-specific proteins, so cancer-specific proteins in that area. The dendritic cells, I told you, were antigen-presenting cells, so they will come and pick up those tumor or cancer-specific proteins in the liver and go and travel to the lymph node. You have lymph node. When you get sick, they swell up in your neck. You have them all around your body, some around the liver. So they will travel to those lymph nodes. That's part of the immune system and say, this is foreign. You should get rid of it. Those T cells are the killer cells. So they will activate the killer cell and say, this is foreign, get rid of it. The killer cell, the T cell, will travel back to the liver or anywhere else where the cancer might be, even if we don't see it on scan, and hopefully take care of it. But I told you the last block is the cancer cells put brakes in the immune system. So when they even get to that area, if we remove those brakes, and that's what the immunotherapy, those other drugs do. So again, it's a complex diagram, and just to show that, just saying, someone gives the term, you get it peace. No, there's a reason why we mix and match different things, and that's based on prior study. And so this is what that trial is doing. So if you go next. And dendritic cell is the novelty here. So I told you that radiation is standard of care. It's not good enough. Immunotherapy alone, it's not good enough. The novelty here is the dendritic cells. Those are those antigen-presenting cells. And, they are pretty much the link between the immune system and the rest of the body. What they do is they survey the body, look for, foreign proteins, foreign antigens, and then alert the rest of the immune system that this is where you should get rid of it. So they're like the link between the external world, body, and the immune system. And so this is the key for this trial. This is what's novel in this trial. Next. And I'm going to go over the schema here briefly. Keep going next. Next. This is where you have to be. Yep. Okay, you stop there. So as part of this trial, and Mr. Nelson went through this, and he's going to kind of give you his experience going through this. But at the beginning, we remove blood. This is actually your own immune cells. Those dendritic cells are immature. They're not fully active. Because I told you the cancer cells have a way to shut down the immune system. We remove them, immature dendritic cells. We have a special laboratory that will activate them, almost supercharge them, so that they're trained to recognize and do what they're supposed to. And while we're doing that, the patient gets radiation, and then we prepare these cells, we treat them. So those are your own cells that we modify in the laboratory, and we grow them. And then keep going, and then keep going. And then after that, we go back and we inject them in the liver that was radiated. So after you radiate it, the tumor is gonna die and release tumor-specific protein in that area. Now we inject these cells that are trained to recognize them, right? And then travel, I showed you the diagram, and alert and activate the killer cell. That's the rationale. So we do that, and we inject every 3 weeks, and you keep going. We inject every 2 weeks, and we give those other drugs, the immunotherapy that is supposed to remove the break. And we do that. A total of 7 injections and infusions. Total course is 6 months. And then in between, we get scans to see how the tumor is responding and make sure there's nothing new. Because if there's something new that grows, then the tumor is not working. So we get scans along the way. Keep going. Yeah, and then after that, went to an observation kind of phase. And Mr. Nelson here completed the 6-month protocol. Literally, I saw him yesterday at the end, and we were really scanned. And if you go next, this is again a summary of the protocol and the inclusion criteria. You have to meet some criteria to be part of the study. But if you go next, yeah, next. So these are his scans. You can stop there. At baseline, I don't know if you can see well, it's projecting well, but the far left, on the far left, I'm showing you 2 different types of pictures from the CAT scan that he had. One is like cut the body this way. And you can see his liver there, and I point the arrow to the mass. That's at the beginning before he started treatment. That's how big the mass was. And the picture in the bottom is a different view, cutting this way, or looking at it. And you can see 2 months into the protocol, you can see what that looked like. You can see it was already shrinking, it was kind of fading away, the intensity. If you keep going, this is at 4 months, again, almost fading away. The arrow is pointing to what we think is disease left, okay? And then this is just, I saw him yesterday, we were doing this, you can barely see anything left, right? There's still a little spot there. We do biopsies to really see if there's active disease, and we do additional testing. And this is what's left. And yesterday I told him, hey, now we're just going to see you every 3 months, right? Just to make sure we do the surveillance. And my hope is that this will not come back. Again, in the sake of time, I showed you other images. But the very first patient we got on this trial in 2019 is 4 years out. I saw her in the fall. She's doing well. She didn't get surgery. If she makes it to the 5-year mark, we call the survivor. That's the criteria. And she did not get surgery or transplant. We don't see that. But that's what we hope for every patient. I don't guarantee that. It's a trial. That's why we have to show that it's effective in a lot of patients, but that's what we hope for. And so you go next. So in summary, steps to take, if there's anything to take away from this talk, get screened. I kind of told you about the different risk factors. Hepatitis B and C is a common one. And talk to your primary care doctor. If you've never been vaccinated or heard about hepatitis B, definitely ask about it. There's a vaccine. So the vaccine can actually prevent you from getting hepatitis B. Unfortunately, it's not widely available. And in immigrant populations, when they were back home, they were not vaccinated. And they never even knew they had hepatitis B. And when I see them, years later, they have cancer, right? And I'm like, this could have been prevented. And I get the history, I read it, I'm like, oh my God, another one, right? That's how I feel. For something that's preventable. The best treatment is prevention, right? So I emphasize that a lot because I look at it, I'm like, this is cheap. It's a vaccine and it will prevent the hepatitis B. For hepatitis C, if you unfortunately you get it, there's actually a cure. There's a treatment that actually will eradicate hepatitis C. So if you get screened, you have it. I know people who are cured since 2015. The drug became available in the market, it's not globally available. So that's the importance of getting screened and talking to your doctor. That could be the difference maker. I would want to be out of a job, honestly, if you could get screened and not get cancer. In Africa, sub-Saharan Africa, hepatologists, not even oncologists, treat liver cancer because they don't have the drugs. So there's only one drug, they don't need an oncologist. So diet and obesity, I talked about diabetes, fatty liver disease. So limit red meats, high fat dairy product, processed food, eat, more fruits, vegetables, have a healthy diet, exercise regularly, that's gonna help you. Alcohol, limit, I'm not saying don't drink, but limit it. And I put there what's considered reasonable, no more than 1 drink a day for women, and then 2 drinks for men, okay? And then smoking, obviously it's a common cancer carcinogen. So if you're smoking, think about quitting. And then needle sharing, that's another way to get IV drug, IV intravenous infection. That's how most people get hepatitis C. And then get screened for liver cancer. If you have any of these risk factors, talk to your doctor. Do I qualify? Do I need to screen? And that involves a liver ultrasound and that cancer marker AFP every 6 months. That's very important because if you get screened every 6 months, the moment we see something that looks like cancer, we can intervene and you can be cured. And that's the difference. 50% of patients get to diagnose at a later stage. That's unfortunate when there's a screening process. Next slide. And so if you get diagnosed with cancer, I would say don't lose hope. What you can do at that point is finding a good doctor that specializes in liver cancer. And that's very important because there are a lot of things that go into finding the best treatment. It's not a one size fits all. Everybody is a little bit different. Sometimes we combine different things. So you want to really be at a center where they see a lot of these cancers, they treat a lot of them, and they have expertise. So finding a specialist in liver cancer. And I work closely with surgeons, radiation oncologists, interventional radiologists. I'm putting there our team at Mayo Clinic, that's specialized in liver cancer. And then I want to give big shout out to our research coordinator, Katie, she's the research coordinator for our clinical trial. Dr. Mr. Nelson knows her very well. Really ensures that for those patients that are on clinical trials, that their experience is good. It's one thing to enroll patients on clinical trial, it's one thing to retain them on clinical trial. And Mr. Nelson to share his journey is very important. And so Katie and the rest of our research coordinators play a very important role. And I think I will end there. I think that's my last.
Thank you. Wow, that's a lot of information.
And I welcome back.
We don't have any on social media.
You have some in the webinar, so we can walk through those really quick.
Sure.
So we have the doctors introduce themselves again. Some people join later and would like to have your guys' information.
Go ahead.
I'm Dr. Ethan Mohammed, I'm a researcher. Sorry, my name is Dr. Ethan Mohammed, I'm a researcher at Mayo Clinic, interested in liver diseases.
Dr. Yena Comfort, I'm a medical oncologist at the Mayo Clinic. I take care of patients with cases of the gastrointestinal GI tract and the liver, and also do research in that disease.
Okay, and then a couple of comments about people stating that they are also cancer survivors diagnosed and healed over a year ago, with hepatitis C being the factor. So those are kind of the things that we have.
Well, I have a question. I heard that you can contact on the hepatitis by not washing your hands at school, touching your face and things like that. Is that another way?
Yeah, so that's one, it's called hepatitis A.
Okay.
So it's multiple hepatitis A, B, C, D, E, F. And so there's multiple types of hepatitis. I only talked about B and C, because those are the ones that typically will turn into a chronic illness. That would cause chronic inflammation and eventually cirrhosis. What you're talking about is really due to poor sanitary, conditions and food contamination. Not as common in this country, but in other parts of the world, Sub-Saharan Africa, Southeast Asia, you can see that. Usually it will cause an acute infection, meaning it will resolve it, not a chronic, meaning over years. Yes.
You go for it, you go. I have a quick question. My dad has had diabetes for over 35 years. What are your thoughts on the Ozempic or Wegovy using as far as reversing fatty liver disease?
Great question. It's an area of investigation. And, it would be an easy way to prevent, but I think they have a lot of preclinical data, meaning in the laboratory, in mice, they're trying to bring that to clinical trial. So I don't think it's ready for prime time yet, but that's a hot area of investigation.
My dad is extremely ill from it. Yeah.
It's an area of ongoing research.
Thank you.
Well, I seen in one of the slides, you said something about the data, trying to get more representation in some of the data. How do we do that?
Yeah, just like this, right? Debunking a lot of the myths, right? Because there are reasons, it's uncomfortable to talk about it, but there are reasons why we don't participate. People from our community don't participate, right? Historical reasons. I could cite the Tuskegee experiment, right? I'm sure a lot of you are familiar. That's where a lot of that comes from. Mr. Johnson will probably tell you when we first met. So you want me to get around. So he could talk about it, but it's coming from somewhere, right? So, but things have changed dramatically. And I'm here to say that because I'm in there, I'm doing it. There are a lot of safeguards and regulations, right? To make sure that you're not treating patients as guinea pigs. I can guarantee you in the United States, for the US, that's not happening. There's so many bodies institutionally at Mayo, in any institution, at the national, federal level, regulatory body, and even internationally, to make sure that when you open a trial or any research, that is ethical, that scientific, ethical guideline. We build up committees that are not just doctors, patients, patient advocates, members of the community, pastors, are part of it, and their voice is heard. So we have to be at the table, that's one reason, and I'm here to hopefully debunk that myth that you're not gonna be at the beginning of it. Like I say that, and Mr. Nelson can probably share his experience, he had the same thought, they were coming from a legit place, and there are historical reasons for that, but that's no longer happening. That's one thing. The other thing, why it's difficult to have more racial ethnic minorities is access, right? Unfortunately, I have to say that, access to healthcare. If you don't have access to healthcare, you're not gonna have access to clinical trials, right? I went to, an event where a patient told me, it's not that I didn't want to be in a clinical trial, I just wouldn't get the mail. I had no answer for that, but access to healthcare, I'm glad we have smart people that are tackling that aspect, but that's another major reason. Education is another one, like, the multiple is really a lot of factors. I don't want to talk that I could give on that, but there are multiple reasons, but events like this, that's why when I was invited to come to this, I said, I'll pay to come do this. Because I'm on the other end where I see, I'm like, oh, we need to do something. And if you don't have people represented, then we don't know if it's working. And actually what's sad is that immunotherapy that I talked about, the group that is predicted or we're suspecting we're seeing right now that's predicted to respond the best to immunotherapy are people who have hepatitis, that acquire liver disease from hepatitis. Guess what? It's a lot of us. I showed you the map. Southeast Asia, Sub-Saharan Africa, Black, African American, that's us. But we're not getting the treatment. We're not even getting in the trial, right? Missed opportunity. And that's what creates disparity. Then we're gonna say, oh, this group benefit, but the people who have predicted to benefit the most are not there. And then it's just gonna widen the gap even more. That's something that we see. So it is very important to be in touch with your doctor, get screened, prevent it if you can, but if you can't, look into all your options. Most of the time, clinical trial is probably gonna be the best option because it's building upon what standard you try to improve. So long answer to your question, but
So on your poll, you said that Black, African American, and Hispanics were more on the end to get diagnosed. And I was wondering if maybe that could be, obviously there's problems within communities that they don't wanna go, they have their things, but could that be a problem with the healthcare system themselves? For example, like, if you said Somalians and Africans also speak different languages, translation, couldn't be correct. A lot of translators not say what they need to say. People do not understand. Another thing, you said that Africans didn't get their vaccine, but when they come here, but nobody tells them that they should take that. You know what I mean?
Right.
So it's like, I know that from my family, some of my family that was born in my country did not take that vaccine.
Right.
When they come here, we don't know until a couple of years later to take that vaccine.
Correct.
It could be within, also, there's parts we could do better, yes.
Right.
But I see that there's also parts that like the hospitals could teach us or help us out with more.
Correct. You're spot on. I mean, access, I mentioned access, and access means access to healthcare. You can look at it different ways, but you're right. Education is another part. So that's what Robbie tell you, he was healthy for 60 years, he's like, I've never been to the doctor. And then the first time I go, I have cancer. I'll let you relate that.
Yeah, it was like, I watched my brother pass from cancer. And, said that ain't gonna happen to me. It's not gonna happen to me. I said, if it do happen to me, I'm gonna fight it. He was fighting, but he gave up, he said, I'm ready to go home. So it's like, it happened to me. He said, you have cancer? The thought process, wow. Is God calling me on this, what I said, I'm not gonna lay down and let this eat me up and kill me? I would have never did this clinical trial because I'm 60 years old, how I was taught. And you're finna be a guinea pig for those people? But he looked me in my eye. I told him, I said, "You want me to be a lab rat?" And he looked and said, "No, no, 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 don't think of it that way." And I seen the sincerity in his eyes. And I said, "Okay, I'll do it. What do I have to lose now? I have cancer. I don't have cancer. You know, I just got burnt spots running around in it because he knew what to do. And he said, I think this trial here," he didn't say another trial. He said, "This trial here is just for you, but it's for everybody, you know, that is willing to do it. You gotta go to the doctor and get checked out." You know, I was at stage 4 already. What other stages am I about to go through? It's time to go home and lay in the bed and talk to the Father, see if you're going there. You have to go get checked out. We as Black African Americans, men of color, women of color, well, women go to the doctor. Any little thing can be wrong. They can smell something, they gone. But men, we always wanna, "I do it tomorrow." Tomorrow is not promised to you. Why put aside what you can do today, tomorrow? We don't go get checked out. And then it prolongs and prolongs and prolongs and prolongs. And then it's too late. Once you finally, look, I started vomiting. The pain was so intense. And I told my wife, "I don't know what's going on." She said, "Well, we gonna find out what's going on." I said, "Well, how are we gonna do that?" "We're going to the doctor." And I said, "No, I'm not going up there. They had me sitting up there too long." I said, "Mhm, mhm. You gonna go today? You gonna go today?" And I went. We won't go to the doctor. And that's bad. I can have a bad cough and I'm going to the doctor now.
And that's my point, you know, so going to the doctor, starting with a regular doctor, primary care doctor, that's your advocate, he's gonna get you screened, he knows what to do. If you do for a vaccine, you need a vaccine, he's gonna get it. But if you don't have access to that, for whatever reason, there's a number of reasons, you mentioned some of them, it's unfortunate. And that's a bigger problem, like actually, and I wish I had a magic solution for that, but I'm glad some people are working on that. So
But look like you answered all the questions there.
Did a pretty good job.
Yeah, it's never put you in a hot seat.
Yeah.
Unscripted.
yeah, let's go.
No, unscripted. But I'll give that to you. But what a powerful testimony. I think for most of us, we heard about cirrhosis of the liver, right? You know, most of us, I mean, that we know a lot of uncles or whatever, aunties from drinking, alcohol, but we really don't really talk about just liver cancer, right? And I think that the young lady over there talks about translation. Some of the terminology that you use, we don't really, we have a translator for like Somalian communities and Sudan communities and other things, but you're an African American translator, right? We tend to forget, even though we speak English, we still have a different dialogue, it's in English that we may call it something totally different than what you call it. And so being able to translate that, right, is, I think, very important. You see very few individuals, African Americans, descendants of slaves, in your hospitals use as translators. Right. We don't tend to value, and really see that because of all the stuff you were saying, my auntie, my mom like that, it was like, I don't know what that is. But I can tell you if I see somebody's eyes look yellow, you got it, boy. You know what I'm talking about? You know what I'm talking about? They know it, right? They know all that. So the question I have for someone talk all day, for you, Mr. Nelson, is you didn't feel any pain up to that to it got excruciating, or did you feel any symptoms, couple years before, anything like that?
Well, I hear it. I hear it from my wife. I just automatically assume, that it pass over,
But what was it? What was it? What was it?
the bowel movement and the stomach.
Yeah.
The stomach, stop your feet, take the laxative, it'll pass over.
So the bowels, was it bleeding in your bowels, or I mean, was it constipation or what?
No, it started wanting to come out my mouth. It started wanting to come out my mouth. It had to come out somewhere.
Yeah.
So the moment I started vomiting, and I'm saying, hey, no, this ain't right. This ain't supposed to be. You know, and the pain. First, I would go 3, 4, 5 days without a bowel movement. Without one, but the vomiting started. I mean, had to really checked out. That was best. And we'll get to that.
Yeah, I want to say, oh, go ahead.
Yeah.
In terms of understanding how to engage in vernacular and being able to, I mean, medicine can include culture, right?
Yeah.
And if I don't understand how to take that information very depth, even for the scientific and medical community, how would I be able to effectively translate that to the general audience? Make sure that in a situation of emotional exacerbation, right? Because you're confused, you don't know what to do. You're having symptoms that you've never been accustomed to having. And then how to make sure that with the time limit that we have, that we are able to understand, in order for him to become the best speaker, he needs to be the best listener, right? He needs to be the best engager, right? Ask the questions in a manner that we can try to get out answers from these people. Like you had mentioned earlier, hepatitis in one way, we know it as jaundice, or in the certain East African population, they'll talk about the symptom, in this case, the yellowing of the eye, as the definition for the actual word of chronic hepatitis infection. So how do we make sure that even the medical community themselves are trained enough that they become the best advocates they can for the patient?
And that takes a village to tell you that, because we have clinical trial navigators, right, that are from a specific culture. Native Americans, the Somali, or some of my trials for consider that. We really break it down for the patient. A patient, Mr. Nelson, I was able to do it. That had Somali patients where I had to call that the JAMA to really come and help, really break it down. And once the patient understood, like, I'm gonna do it right away. Yeah. Right, that's the difference. So having a lot of us from different cultures involved in the process. Oh, right, he could tell you, he said if it wasn't me, he wouldn't have access to
I
that.
probably wouldn't have,
Right,
probably wouldn't have did it.
right, so that helps, with that initial contact to say, I feel confident with what you're telling me, because there's a big distrust, or again, reasons that we all know, historical reasons. So having people from different cultures, you know, helps not just bring the patient in, but retain them, keep them home, because it's a journey, it's not a one and done. And so that's very important.
And going off of what you just mentioned, even from the research standpoint, we were able to recruit over 1,000 individuals with immigrant backgrounds, whether they're from East Africa, West Africa, Southeast Asia. The thing that worked in that process was us showing up, physically being present, being able to engage, talk about what their concerns are, what do they understand, what do they not understand, also but at the same time having the humility for us to learn what we don't understand and how do we improve on them, covering each other's blind spots, for example. These navigators are important, but what's even more important is building the infrastructure to allow these navigators to be able to be empowered, to allow these discussions to occur. Like you had mentioned, Mr. Nelson, you felt comfortable. There could be multiple reasons why you felt comfortable. But I could bet one of the reasons why you felt comfortable is you look at him, he is sincere, but also there's a relation that you have with him, a connection that you have with him, whatever that connection may be. And usually sometimes when we see someone who looks like me, we almost always feel that that person will have my best interest at heart. And we would like to open up those conversations. So we need to actually think about and be intentional about these conversations to say, what does the next doctor look like in the future? We talked about African-American males and Black men. We are highly represented when it comes to having mortality to various types of diseases that are preventable. But we are the least amount of representation when it comes to medical doctors or researchers or anyone in that category. So what do we need to do in this facility right now, this table right now, this conversation, to allow a path to be paid for those students to be able to take care of us when we're old and senile, for example. My father is in the hospital right now with multiple medical complications, right? If he didn't have family members around him to advocate for him, I'm not sure if he would be alive or have this quality of care that he's getting at the moment that he is getting, right? Although there's possible concerns and we're gonna have the complicated situation that we have to have discussions about. But it's about building that type of narrative and that type of future. We can't talk about health disparities forever, right? Martin Luther talked about the same thing 20, 30 years before I was born. And now today is my 37th birthday and we're still having the same discussion again.
Another thing, I'm from Illinois. And when the doctors say research, we would like to do a research. Illinois pay for that research and pay that person to do this research for them. Minnesota don't. Okay, even when you donate blood, Minnesota don't give you nothing to donate your blood for research. We can go to Indiana, we can go to Illinois, you can go and they pay you for your time for research. That's a main factor in men of color when nobody says anything about it. Plus, you gotta think about people have to live.
And it goes back to access, because participating in a clinical trial, you have to have a sense of support system, right? Usually you need family support. So once you take you to the doctor, they have to take excuse from work, right? And when it becomes burdensome, sometimes have to become the So it has implication psychosocially, but also financially. And obviously racial and minorities have certain socioeconomic institutions that doesn't allow for that. So you ask about reasons why, money is the other reason why. You know, because I know I have this family member that has to be working part-time now to take care of it. What is it? It's all of that. So it's a very complex problem. But we've been talking about it. We need to start acting. And like you mentioned, it's not new. We've known about it. Now let's practical in do our part, right? The excuse will be, oh, it's too big for me to handle. No, do what you can do at your level. Yeah.
I know one of the things you talked about, I think you want to do, finish in the state, part two of your presentation. You want to talk about more of, the community engagement or community partnership, outreach, to help, close those disparities, those gaps. What are some of the things that you have done in the past and some of the things that you're planning to do in the future?
Yeah, that's the $1 million question. Continue to organically grow. First and foremost, let's break it down to basic human interaction, right? Two people meet each other. There has to be some level of understanding of who the other person is. That's just a level of comfort, some level of trust. If that doesn't exist, then the relationship between those two individuals will not last, right? Whether it's difficult conversations that you will be having, whether it's conversations of confusion, and you go on that journey. But at the end of the day, it's about empowering one another and growing from one another. And this, as Mr. Nelson had mentioned, he trusted my colleague here in taking care of him as a patient. And if I don't trust you as a community member coming or as a community member, how do you expect a researcher to be as successful or a clinician to be as successful as they are? Now, what are some of the ways that we've worked on building those relationships? Number one, where do people go? Where are the places that they frequent? Religious establishments. We're here at a barbershop. Within this community, there's been papers published on how the barbershop is a source of information dissemination to various types of diseases, published in high journal, impact journals. Other places could be cafe shops, for example. Go into those communities and be able to say, okay, these are questions that we have, but we don't want to impose. How do we engage and have those dialogues and those discussions? Let it organically grow. I have one of my mentees here who is helping, which we call it the homelessness issue up in the Twin Cities and here in Rochester. One of the things I told them first was, you can't go up to people and just ask them, are you homeless, right? Be available to them, right? Let them see you, recognize you, be there frequently, build that trust bond, help provide some of the resources that they need, and then have those discussions. Because as a human being, why would I show you my vulnerability if I don't even know you, if you're gonna come back tomorrow or the day after, or if you're gonna be gone? And oftentimes, part of the, historical negativity that medicine has done to minorities, whether they're of African descent, Hispanic descent, et cetera, is they would come in and do what we call helicopter research. They'll, recruit you, take your samples, and then just walk away and never come back. So going into this, you need to be prepared and primed to understand all these different factors and say, okay, what is the best way that we can be holistic about our approach to ensure that this isn't for the short-term gain, but it's for the long-term gain, long-term plan. Even if I'm gone and I'm, in our medical training, research training, we're here for temporary, and then we move on to the next opportunity. But to build an infrastructure in place that when you leave, it can run on its own. And that happens through you guys, through us, through these discussions, right, through partnerships. Him and I are just two individuals, but when we leave, who else is gonna be plugging in is a question, be part of that partnership. When you start thinking about that and being intentional about that.
Yeah, no, I agree with everything he said. I think, you really have to build trust with. I'm not from the Somalia. But if it weren't for him, Dr. Nasra, to give me access to that community and show that I'm genuinely care about that. I mean, I would not be doing the work that I'm doing with them because you can come and talk to them, they're not gonna do anything. We did a video, I'm not sure it was featured, it was streamed, for the Somali community. The way I thought about it initially, was completely wrong. Because I was like, I was supposed to do it, and I hired an actress this age. But then if I want to work with a Somali Health Advisory Council, right? Get inside, okay, is this appropriate? Like, no, you get a 20-something-year-old, the message is not gonna go through. You need someone in their 40s or 50s, that's something that I didn't have to be witnessed. So you really have to be humble enough to listen to the community, forge that relationship, that trust, and not just coming and going. You really care. I mean, there are long activities in the Somali community. I know when the Independence Day is, we go to health fairs, you have to have that constant presence in the community. So you truly care. He's not just here to get his research done and everything done. How many people are willing to do that work? Very few. Right? But that's what it is. Do you have any questions in the audience?
I just wanna say, I feel that the percentage is down too, not because you don't have access to medical care or we're not going. I'm a person that gets my mammograms, I get my checkups yearly, every 6 months, and I witnessed that, I get discouraged because when I go and I say, hey, I got something wrong with me, they're like, here's some narcotics, go home.
Yeah.
They don't listen. I've been in the hospital for 3 weeks, saying something's wrong, they've been brushing up. I just found out I had a tumor a week ago. And so, they just don't listen. And we need more people like y'all that listens. Don't think I'm here just to, I don't know, like wow y'all or take your time or get narcotics. Like I need help. I got insurance. I'm doing the right thing. And like when I'm asking questions on possibility, they have attitudes. Like they're getting paid to just to get paid. They're not doing their job. They're not helping. They're not comforting. They're not getting people to help you to understand, to cope with it. They're just saying, this is what you got going on. Go home.
Yeah, sorry. First of all, sorry. Sorry about that experience. And sorry for the diagnosis. I could feel the pain, the frustration is something that I've lived myself, even as a physician, right? And it's not just the stereotyping, the premature closure, even high-profile celebrity. You can read about Serena Williams, her pregnancy. You have the typing Serena Williams. A lot of things that happen with her health is because probably she was African American. There's that premature closure, right? Stereotyping. We say, okay, you put you in this basket and then they don't think about anything else, right? Oh, you're seeking for pain medicine. That's a common one in the emergency room. And you may have real legit pain, right? I think that the tickler, between the sickle cell anemia all the time, right? In the ED, the one time they actually have the true crisis, right, is dismissed. And I've seen it end up in death. So it's unfortunate, but to go back to this point, we need to improve workforce diversity. That's why we need a lot of us in the system. Creating a pipeline, right, beyond just this, creating a pipeline from high school, middle school, I'll even say, because trust me, I was in medical school, first year of medical school, you know, with Caucasian high schoolers, right, because their parents had access, rounding with us. I'm a first year medical student. I'm like, how am I supposed to compete with a high schooler? You doing this in high school. I didn't get to do that till I got to medical school, but that's because they have the access. So if we don't create a pipeline from high school to college to medical school, to have more of us, right, in the system at the table, this is gonna keep happening, right? So like I said, it's very complex. We have to attack it from many fronts. It's not just access. I agree with you. It's not just about the money. It's not just access. There's a lot that goes into it. I know, right?
Actually loves their job and wants to make change.
All right,
I think a lot, I don't care if it's the best hospital in the world.
all right.
I see a lot of that with the secretary, with the nurses. It's a chain reaction,
Right, right.
and it gets you discouraged with points like, I don't even wanna go there, I
Right.
might as well just.
Yeah.
Let God do what he has to do.
I feel your pain, but I don't want that attitude, right?
Well, I don't have that.
No, no, I know, but that's because Nelson had the same attitude initially. He was
Yeah,
like,
yeah,
I'm
yeah.
not listening.
Yeah.
But if we do that, then we're just gonna widen that gap even more. Right, and who loses in the end? We do. So it's gotta start somewhere. Your story is powerful, it will help the next one. That's what Mr. Nelson is doing his part right now.
I'm
His-
a advocate, I'm strong and I'm assertive, and I'm not gonna let anybody tell me I don't need help. But the next person may not feel like that,
Right,
may get discouraged, and that's just not cool.
right. I hear you, Mr. Ross.
I just have a quick question. I'm trying to figure out what the disconnect is with Mayo Clinic and the P-TECH and C-TECH programs here in Rochester. There should be some implementation of, the P-TECH program focuses on nursing. P-TECH focuses on trade. Why are we not having instructors that are of color to initiate contact at the school to bring interest to retain and sustain doctors of all colors? That's why I'm wondering why that's not happening. Like, I know you probably don't have the answer to that, but I'm saying that would be something where, in my mind, I'm looking at research. I'm looking at being a doctor, right? Or I'm looking at being a nurse. Why are these not implemented and given to kids in an early age, like you said, junior high school, given an opportunity to know that they can do those?
Again, I don't know the details. This probably happen at a higher level. But what I would say is I've been involved in mentoring programs, right? There's this rise. Yeah, I've mentored over the last just couple of years, couple of high schoolers, one including now, interest in health related careers, right? That's one way, right? I went to school and give a talk on medicine in general, right? Which I didn't have. I mean, I'm originally from Cameroon. You know, when I came here as an international student, there was no one that looked like me, right? So even going to medical school, it was two of us, one from Haiti, one and me, right? We had the same journey. No one that we could relate to say, okay, who can I talk to that walked this journey, right? And you need that. So when I do that now, it's because I walked that journey. I know what it's like. When I talk to these high schoolers, they have to see me to say it's even possible, right? So I'm not sure what's happening at a bigger level, institutional level at Mayo Clinic. I'm definitely not part of this conversation, but I know there are a few programs that I've been part of. So there's definitely, we need more, for sure. And whoever has a team, you know, people like Coach Andre, Manal, the NAACP, those are the people that need to put pressure on institutions. Because we can't talk the talk, we have to walk the walk.
Thank you.
So what are we, oh, you got something, Mr. Lee? Go ahead.
Yeah, I was just gonna say one thing, and I'm just kind of piggybacking on what the young lady said here and kind of what we were talking about, like, I love my doctor. But she, again, she has a different walk of life, she's a Caucasian lady, fantastic doctor. But how do I demand this from her? You know what I'm saying? Do I walk in and say, look, this is what I need from you to do, this is what I need from you. can you do that for me? Because I know she's not gonna understand when I'm, but you know, I'm not sure how to approach my doctor. Because a lot of people don't, and I mean, they don't know what to say, how do I do that?
I would say, I won't speak for every doctor, but I would say at least try, open that door, right? Because my mentor, my very first mentor is a white woman. I would have never guessed, right? But that's because she cared. She cared. I would have expected someone else to say, hey, but she cared. She learned to know me, to understand my journey, and then see how she could help me, right? So it starts with caring. If they care, they will be open to learn about, to understand your cultural, psychosocial environment. There are a lot of programs right now to make providers in general more culturally sensitive. I didn't know a lot about the Somali community. I'm from Africa, but I'm not from Somalia. Have I learned a lot? Yes, because I wanted to, because I care. But on the provider to really make that effort to say, hey, I'm willing, open, humble enough to learn about your culture to help you. Now, I can't speak for everybody, but that's what it takes. But open that door, you'll be surprised. I mean, I call her my academic mother. She's a white, not a black man.
So the question I had is, yeah, they're bad providers, like, you know, like every field, there's a mixture of people.
Right.
But how can we teach our community to advocate for themselves? And we understand they don't have the medical background, and you know, there's a lot of dismissing of WebMD and, you know, Googling. So how can we teach our community to advocate for themselves when they get those scenarios, you know? The same way we teach our kids how to deal with the police, you know? How can we teach them to advocate for themselves and stand up for themselves in a way that's not rude and that doesn't make them get into problems?
Right.
I'm gonna take a crack at it.
Anybody tackle that one?
In life, everyone has to be okay and comfortable with being uncomfortable, right? Sometimes, as the sister had mentioned, you have to be assertive. Some people might misconstrue that as being disrespectful, dismissive, rude, whatever verb or whatever word they want to use, right, to describe that. Brush that off as much as you can possibly, human possible, brush that off. If we want to understand something, we want to understand the basics of what that is. So the large medical jargon is given to you. Wait a minute, hold up. Break it down, draw me something. What does this look like? How is this impacting this? Why is this medication working? How is this medication working? Right? So I can understand it, so I can explain it to my loved one who is ill, or if I'm the patient myself, so I understand it, so I know I make the best informed decision. And sometimes that will include us making multiple repeats of the same point. Just as I had asked earlier, that the physician or the care provider should be able to provide, or at least frame the questions that he or she is asking from multiple angles to understand the patient's problem. I also think that the patient, him or herself, or the care provider should be able to ask those questions if they don't feel like they got the answer that they needed, or understand maybe what the answer is from multiple lenses as well. It's a give and take from both sides. Look at it as a dialogue. Oftentimes these physicians, I apologize, but he probably has a small window of time that he can see, right? And he's being pushed or hounded or whatever else have you to go in there quick, get out, make a diagnosis, make a little quick chart, go home, next patient, right? But how can you make sure that in that conversation, you identify, okay, these are the symptoms I'm having, this is how it's occurring. But at the same time, I don't understand what you're saying, can you please repeat it? Have to reframe it, rephrase it, whatever way you want to do it. Obviously, there will be some times where you'll find hesitancy and they'll repeat the same thing over and over again. You just say, I understand you, I hear you, but I don't get it. There's nothing wrong with it. No one is gonna walk, he's not gonna walk away. If you tell him you don't understand, right? You can't. In his professional oath that he took, he can't walk away, or she or whoever. If you, the patient or the patient family, say that I don't understand what you're saying. Oftentimes we keep our mouth shut because there's information overload. They are not taking the information like you had mentioned, Pastor. You have to understand how we speak. You have to understand our culture. Right? And if you don't understand that, we have to teach them. How I understand it, is this what you mean? Is this what it's related to? And then see where the discussion goes at. Oftentimes, you'll be surprised at the end, they'll say, thank you for being an advocate, or advocating for your father or your mother and what that.
We got a question from the online audience, because they may have missed it, but besides early testing, what can be done to lower the risk?
For liver cancer?
Yeah.
Yeah, I think I mentioned that, early testing screening is in the lifestyle, dietary changes, right? I mentioned a number of risk factors from alcohol, right? Your diet, liver disease, diabetes, you gotta control that. Your lifestyle, I mentioned hepatitis C, one way you get it is a blood-borne disease, right? So IV drug use, sharing needles, tattoos, you gotta be careful about that. That's how you get those. And then there's some things you can't control. Or we did talk about some of the genetics. You have no control over that. But again, if you plug in with the right doctor, they can see abnormalities early on. And say, you know, we need to look further into that. So really, there's what you can do, what you can control is lifestyle, dietary changes, the way you live your life, and then make sure you at least plug in with a doctor. And they will take care of that.
And Mr. Nelson shared some of his symptoms, the early on symptoms. Can you kind of break that down, what was happening to give him those, those symptoms?
Yeah. So when you have this type of cancer, you have cirrhosis, right? So the other thing is, it also had cirrhosis of the liver. And I talked a little bit about what that entails. That comes with other things, not feeling well, the nausea, vomiting, bloating, swelling, you have fluid accumulation build up from that. So the pain was likely from the mass, right? Here, told you what it looked like at the beginning. It's right here, you can't miss it. And when it's that big, you'll feel it. You probably brushed it up and grew, something probably a few months, maybe even a year to grow to that point, and those are the symptoms that you probably brushed up. I'm feeling something there, but hey, I'll be okay. He never got to, wasn't too late, too advanced. Some of the people who are advanced actually have more serious symptoms. In addition to the jaundice, bleeding. That's the other thing. So when they vomit, they actually vomit blood. Because those veins that I mentioned in the esophagus and stomach that are varicose, they bleed easily. So when they vomit, it's like, oh, they're vomiting what we call coffee ground. It looks like coffee ground. Sometimes when they bleed, because the hemorrhoid veins also are bleeding. So that's more advanced. Maybe the cirrhosis is pretty advanced. But those are something that we can see. And even at its worst stage, and I hope it doesn't happen often, is confusion. I told you liver cancer, liver is a detox. One of the toxins is called ammonia. If your liver is not cleaning that up, it goes to your brain. You become confused. We call that hepatic encephalopathy. So it can manifest in different ways. He didn't have that because he wasn't that advanced. But what he had for his stage was appropriate. But again, it was a little bit of thing, kind of what we call intermediate.
One more thing about the liver in general, is that, I don't know what he said, the liver isn't like other organs of the body in which, if it is infected or if there's a problem, you can see the disease or the symptoms at that time. This is something that takes, for most part, decades to develop. The liver re-heals itself, right? For every damage you do to it, it tries to in other words, re-cure itself, right? So as he had mentioned earlier, as more and more of those scars are being made, right, the harder the liver becomes, then it's very difficult to reverse it. Whereas other parts of the body, if you had an issue with your kidney, you'll know as soon as possible. If you had an issue with your heart, you'll know as soon as possible, right? If you had an issue with your lungs, you'll know it, in a relatively short period of time. But the liver is something that can develop over a decade, not decades. And then when you do develop, people are like, what happened to me? I'm a healthy person. I haven't had any of the issues. I didn't drink, for example, or do all those things. But in some populations that we study, viral hepatitis, for example, might be the issue, or the toxins that you're exposed to due to your dietary habits might be the issue. So I think early screening in general, having that conversation with the physician, say, listen, this is what I read. These are the things that I've seen. This is high within this population in terms of disease burden. I come from this community. Can I get tested for these things? And I think from a preventative measure, a physician, primary care should say no, right? These are things that we can be proactive about earlier on.
Yeah.
Now, moving forward, you touched on it earlier, and you had mentioned about Ozempic and fatty liver disease. Liver cancer in the U.S., the highest, one of the highest, if not the highest, contributing factor for liver cancer, cancer mortality can be fatty liver disease. So we're getting bigger. We're having a lot of cardiovascular disease in the community. We have a lot of high blood pressure, we have a lot of cholesterol issues, we have a lot of diabetes, we have all these things that also contribute to your liver's ability or inability to be able to function optimally, right? And there's connection and correlation to that, which we'll talk about another time, to other parts of your body, right? Not just localized, but other parts, other organs of your body that will be impacted by that. So we have to think globally and bigger, right? And larger in terms of how we take care of the liver in a manner that we are hyperactive as a community.
I'm gonna give y'all the last words. I'm gonna start with, Mr. Nelson. What would you want to tell the audience and those out at, social media and?
I will tell you if something wrong with it, go get it checked out, don't wait till it get too late. Men do it all the time. I won't do it no more.
Yeah, I mean, it's, I could say a lot, but if I really wanted to take one thing away from here today is that the best cancer is no cancer, right? Prevention. When you don't have the means, we talk about socioeconomic barriers, right? Act on what you can, right? And prevention is cheap. I'm serious, from the vaccine to lifestyle changes to routine yearly physical, right? That's the cheap part. You don't want to wait till it's too late, right? So what we can control, I know there's a lot we can't control, we talked about all of it, but you can control prevention. You can talk to your doctor. You can get a vaccine if you need to. And so that's what you can control. And if you do unfortunately get cancer, talk to people, find the best doctor that's going to advocate for you. And that could be.
For me, I would say at a communal level, we have to inform each other. We have to have these types of conversations. People who are like Mr. Nelson to be advocates, us being part of that and galvanizing a group that will be able to disseminate information, like you had mentioned, the symptoms, what are the signs, what are some of these issues, how do we navigate through the system? I feel like a lot of what we have gone through from a medical standpoint has some sort of societal impact that we need to change or influences that we need to change. And making sure that individuals who have positions of leadership within their own respective communities are those people in the forefront helping us to lead these efforts in this.
I could add, because I could say a lot, but to go back to the point, sorry. I get emotional.
Go ahead.
Yeah, because it's real life, right? We have to advocate for ourselves.
Yeah.
Answer of all of these problems, yes, we have our part, but lies in the majority, right? And we have to demand it, right? We have to do our part, but we have to demand it. And small talks like this, coalitions like this, is what we need more of, right? Because if you're not coming as a united front, you can't get that seat at the table. So this is really important.
I'm like, you sweating too, huh?
Sorry, I get emotional. It's real life. It's real life. It's real life.
You brought the passion stuff, but we do want to thank, me and Bud really want to thank, all y'all in the audience who came and social media, it's y'all precious time, and Manal and Mayo and them for, choosing this spot to be able to do it. I think this is the second one we did, partnered with Mayo, Manal, and we had great feedback from the community, so we don't want this to be a one-time thing. Like you said, talking about hit them in and out, talking about, so, continue to come, Mr. Nelson, you're living proof, you didn't turn into a mute. I was thinking about split. Okay, but you good to go, you're not split, you right? You're good to go, so you could do, out there, y'all can do clinical trials, right?
Yeah.
You won't turn to splitter. There's a roof right here, he's all right. You got the, we used to call it drops. I'm just joking and everything like that. Thank y'all for tuning in and,
Also, before we leave, if you got any questions for for our panel, please type them in and they will encourage them to come back and answer any questions or concern, at any other time. And if you want them back, ask for them back. They just might come. Thank you for tuning in.
See our post survey, trophy, and, and it'll pop up here.
Okay, wait, where's the, we good?
Right.